In this lecture, we'll have a few miscellaneous topics. These topics are not in the book, but the slides for these topics were emailed to you. So these topics will include SIAD, fever in children, BB formulas, methanol toxicity. We'll have some questions and answers when just questions and answers, mastitis, and nipple yeast infection. SIAD. SIAD is the syndrome of inappropriate antidiuretic hormone secretions, and the patient will have excessive antidiuretic hormone without a stimuli, without any reason to cause that. And usually the stimuli are increased osmolarity or hypernatremia. But in case of SIAD, there is no stimuli. And this will lead to water retention, and this causes dilutional hyponatremia. Dilutional hyponatremia means the sodium level is fine, but the problem is there is lots of fluids in the body that dilute the sodium, so the patient has dilutional hyponatremia. There are drugs that cause SIAD, and common drugs are tricyclic antidepressants and SSRI, especially fluoxetine. Also, vinca alkaloids, vincristine and vinblastine. Some anti-epileptic drugs such as carbamazepine and oxcarbazepine, and a few other drugs like ACE inhibitors, MAO inhibitors, phenothiazines, haloperidol, chlorpromamide, nicotine, cyclophosphamide, NSAIDs, thiazide diuretics, desmopressin, oxytocin, omeprazole, and colfibrate. To manage SIAD, we discontinue the offending drug, and this is the first choice. So the most important thing to do is to try to stop the medication that causes the symptoms or the problem. And then we try to manage the hyponatremia. Remember, this is dilutional hyponatremia. So what we try to do is we try to restrict the water intake to 500 to 1,000 milliliter per day. So this is to give the body the chance to get rid of the extra water in it that causes dilutional hyponatremia. So this way, the sodium level will go back to normal. We also may use furosemide to remove water plus 0.9% sodium chloride to avoid hypovolemia. If the patient has severe hyponatremia, we may try to use hypertonic saline solution 3%. So basically, what we give the patient is more sodium and less water in the 3% sodium chloride. So we're trying to put more sodium, but we put it in a higher concentration to fix the hyponatremia. What if we cannot stop the offending drug? For example, the offending drug is an anti-epileptic drug, and we have a concern that if we stop it, the patient may have seizures. Then we need to monitor the sodium level, and we need to monitor the symptoms of SIAD. And symptoms or common symptoms are nausea, vomiting, fatigue, restlessness, headache, confusion, loss of energy, muscle spasm, and weakness, seizures, loss of consciousness, and coma. And there is one drug that we can use to treat SIAD if we cannot stop the offending drug, which is the miclocycline. The miclocycline increases the blood sodium and decreases the urine osmolality by inducing nephrogenic diabetes insipidus. So basically, it will make the body releases more water than salt in the urine. So it decreases urine osmolality. And it increases the blood sodium. So the body will start to retain the sodium, and instead, the body will pass a urine that has less sodium. Another agent we can use to treat SIAD is oral urea. Oral urea will increase water excretion in the urine, and we may also consider using lithium. Fever in children and how we can measure the body temperature. So for newborn or children less than 5 years of age with mouth breathing, they breathe through the mouth. We will use rectal body temperature. Rectal body temperature is not for the premature babies or for patients who have reduced immunity or for patients with rectal problems. So rectal body temperature is not for these groups. Rectal body temperature is usually higher than the mouth temperature, and that's why we usually deduct 0.5. So if we measure the rectal body temperature and it's 39, usually this is about half degree higher than the mouth temperature, so we usually reduce it by 0.5. For children more than 5 years and in adults, we usually use the oral thermometer. This is not for mouth breathers and not for patients with dementia because they can, they can just break the thermometer in their mouth. And the patient should avoid any hot or cold drinks for 10 minutes um, before using the thermometer. For those who are 3 months to 5 years who cannot use rectal, and we said there are some groups that cannot use rectal, like premature babies and patients with reduced immunity. In this case, we can use the armpit. The armpit is half degree lower than the oral temperature. So in this case, if the armpit is 38, we have to add half degree and it becomes 38.5. What about the ear thermometer? Ear thermometer should not be used for children less than 2 years of age. And ear thermometer actually does not measure the body temperature. It measures the core body temperature and then convert the core body temperature into body temperature. And sometimes there's some inaccuracy converting, like that the device, there's some inaccuracy converting the core temperature to body temperature. The advantages of the ear thermometers are they reduce disease transmission because you don't put anything in the mouth that can be, transmit diseases. It is fast, and less effect of external factors. So, for example, if the patient drinks something hot or drinks something cold, this will not affect the temperature reading. Baby formulas. So here we'll talk about the different baby formulas. The first one is cow milk based, and this is the one that's most commonly used. The problem with the cow milk based formula that it contains more protein than the breast milk, and this is a problem for infants because they may not be able to digest the protein in the cow milk formula, and as a result, they may develop gastroenteropathy when they develop things like, abdominal cramps and abdominal pain, and they get fussy and they have lots of gas. The cow milk based formula, there are two types. There is the whey based formula, which is a soluble protein, and this is usually the best formula because it reduces emesis compared to formula that contains casein. And usually, cow milk based formulas are used for full term babies. There are some cow milk based formulas that are lactose free. However, they reduce mineral absorption and increase bacterial colonization of the GIT. But of course, these are for those who have a problem taking lactose. There is also soy protein based formula. Soy protein based formulas, by definition, are lactose free, and all of them are iron fortified because the soy protein does not contain iron. So they have to add iron, and by definition, because they are milk free, they are lactose free. These are the soy based formulas are used for full term, but not for all the children. They are used for children with galactosemia and for those who has lactase deficiency because by definition um, they are lactose free. And they are also used as supplemental formula when the mother is vegetarian, or if the mother is vegetarian and the mother does not want to give the baby any animal products like cow milk. So if the mother is vegetarian and doesn't want to give cow milk to the baby, then the mother can use the soy protein formula. And soy protein formula is not for infant who develops enteropathy with cow milk. What does that mean? As we mentioned before, cow milk is can be heavy on the GIT of the baby, and the baby may not be able to digest the cow milk, and as a result, the baby will have gas, get fussy, have abdominal cramp. Switching the baby from cow milk to soy will not help. Will not help. 30 to 60% of babies who develop gastroenteropathy when they use the cow milk formula will develop gastroenteropathy when they take the soy protein formula because soy protein also has lots of protein, and the baby may have the same problem digesting the protein. Okay, so what we're going to do with these babies who cannot digest the protein in the cow milk based formula? If the baby has a problem digesting the protein in the cow milk based formula, we can use a formula that's a specialized formula that's called hydrolyzed protein. So what we do is we take the cow milk and we hydrolyze the cow milk in the lab. So basically, we try kind of pre-digest it, and then we give to the baby partially digested cow milk, so the baby doesn't have to do all the digestion by himself. So there are two different types. There is the whey formula, it's partially hydrolyzed formula, and this is used as supplemental to breast milk. And there is the full casein formula. This is for infant who cannot tolerate the cow milk or the soy protein. It's also for kids who have cystic fibrosis, long-term diarrhea, cholestasis, short bowel, and other conditions that can reduce absorptions. Absorption. So hydrolyzed protein formula are commonly used for those who have problems digesting the protein in the GIT, or those who have gastroenteropathy when they take the cow milk based formula. Sometimes the child, even with the partially hydrolyzed formula, has a problem digesting. So in this case, what we can do is we can give amino acid based formula. So um, we take the cow milk and we don't only partially hydrolyzed, no, we completely hydrolyzed. So the baby will actually drink amino acids. No digestion is needed. So this contains amino acid, and usually for severe cow milk intolerance, who also cannot tolerate the hydrolyzed protein. Sometimes we need what we call thickened formula, and this is particularly important for children who have or infants who have excessive regurgitation and those who have problem for weak swallowing reflex. This is to improve swallowing. And we mentioned before, sometimes even in elderly, when they have a problem swallowing, they add a thickening agent to the food, something called pectin, because the thicker the food, the stronger the swallowing reflex. So that's the idea of the thickened formula. It's used for children who have excessive regurgitation and for children who have weak swallowing reflex, because the thickened formula will improve swallowing. Okay, so what about iron? Does the baby need to use iron fortified formula? So the when we have children and the children is 9 months of age or less, okay, they need to use iron fortified formula. So if the baby is not fully breastfed, if the baby is not fully breastfed, and the baby use either formula or mix milk with breast milk with formula, then up to 9 months of age, the formula has to be iron fortified. However, between 6 months to 9 months, we may not need iron fortified formula if we give the baby other sources that are iron fortified. For example, we give iron fortified cereal, for example. So if the baby is not fully breastfed, then the baby will need an iron fortified formula from birth up to 9 months of age. However, between 6 months of age and 9 months of age, we may not give the iron fortified formula, and we may instead try to give iron fortified cereals or biscuits like arrowroot or something like that. What about a child who is fully breastfed? A child who's fully breastfed. For a child who's fully breastfed between 0 to 6 months, no iron is needed. No extra iron. By iron, I mean iron supplement. So if the child is fully breastfed from 0 to 6 months, no iron supplement is needed because the baby will be getting enough iron from the breast milk. Remember, please, this is fully breastfed baby, doesn't have any formula. Between 6 months and 9 months, we need some iron. But this doesn't necessarily mean ferrous sulfate and ferrous gluconate. Again, it can be something like iron fortified cereal or something like that. All the children must remove, or all babies must remove 400 to 1,000 units of vitamin D daily. And another common question is, what about this homogenized cow milk, like the cow milk that we use at home? So, can we give the baby homogenized cow milk? Usually, homogenized cow milk should be delayed until the child is 9 to 12 months of age, because the homogenized cow milk generally is low in iron. So, usually, the homogenized cow milk start preferably at 1 year of when the child reaches 1 year of age. How do we store baby formulas? Once opened, we can keep the baby formula at room temperature for 1 month in a cool, dry place. When it's unopened, it's still at room temperature. But once we open it, it has to be in a cool, dry place, and it's only good for 1 month. How do we mix baby formulas? Usually, it comes with a scoop to measure the amount. So usually, we use one scoopful plus 60 milliliter of very hot water. We can get the tap water and boil it for 2 to 5 minutes, and there are some commercially available prepared water for this solution. So it's kind of water that is pre-boiled, water that's pre-boiled, and it comes in small containers, and the mother just open the bottle and add the formula to it. We may cool the formula in the fridge, because usually if we don't use the commercially available pre-boiled water, we will use very hot water. So we may cool it in the fridge, but we must use the formula within 24 hours. Once